So this is a big talk, and I'm going to be using the example of the Eastern Congo Ebola outbreak, which took place between 2018 and 2020 as a reference point for this talk, and specifically the example of vaccination, hence the title, Not Just Needles and Arms, the importance of community in public health response, which I think COVID has actually shown us very significantly how important it is really to have that community engagement and probably a bit of a deeper understanding rather than just trying to roll out, trying now, there we go, okay. This is a collection of headlines, again, illustrating some of the concerns that went on during the North Kivu Ebola epidemic of 2018 to 2020, significantly focused around mistrust of the community and rumors that circulated regarding the Ebola response in general, significant rumors that Ebola had become a business, that there was international interest in prolonging the epidemic, that Ebola was not real and it was just simply a money-making venture for various interested parties. So we'll get back a little bit to how that came to be and what the impacts of it were on our response. So why does community engagement matter so much? If we're looking at one aspect of a public health response, for example, vaccination, a poor response from the community or poor acceptance from the community impacts the acceptability of other health interventions as well. These could be public health interventions, but these also could be individual health level interventions. And again, looking to COVID, what we see is an erosion of both public and individual trust in science, in medicine, and in a lot of health interventions in general. And we're seeing declines in things such as vaccination rates for childhood, which were already on decline before COVID began, that really show the impact of poor understanding of interventions in one area having an impact on future programming in another area. Another thing that's key to consider, particularly in various global health responses, is there's often a very significant overlap between health interventions and security interventions, and in fact, a securitization of public health activities. In Congo, one of the things that we saw as there was more and more concern on the part of the community, in fact, leading to violence, that the response was that public health teams, and very often vaccination teams, traveled with armed escorts. And in an area where there's already a very high level of distrust between the population and the government, armed actors such as the UN or the police or the military are often not trusted, and associating health activities with that securitization, in fact, can undermine the perceived neutrality of healthcare interventions. It can undermine public faith in the acceptability and the utility of those interventions, and certainly leads to an environment of confrontation rather than open questioning and dialogue regarding a lot of these interventions. Community resistance as a term, and you've heard me use it already a couple of times, is often cited as a barrier to public health response. And again, I'm going to use the example of vaccination, but we can certainly think of a lot of other areas where this is in fact true. Public health planning rests on the premise that in most situations, faced with the threat of an infectious disease, that most individuals would be in favor of vaccination for themselves and their families. That's a basic planning premise, that planning programs need to take into account access issues. There may be the need to answer basic vaccine-related questions. But again, that underlying planning premise is that vaccination is something that most people want and that most people will accept. However, this is not necessarily the case for all groups. It's not necessarily the case for all groups within a certain community, and certain communities may have significant concerns related to vaccination. And addressing hesitancy by insisting only on the importance of being vaccinated, which would be individual protection, community responsibility, community protection from disease, ignores the reason that many of these groups are reticent in the first place. It's a lost opportunity as well for communication around health interventions in general. And in fact, it's likely to be unsuccessful. If the response to a community or a group being against vaccination is to continue to repeat the importance of that vaccination and why it's someone's individual responsibility to become vaccinated, that's not likely to be a very successful message. It also risks further alienating communities and making the underlying goal of the reduction of the number of cases, deaths, and serious outcomes less likely. Community resistance, again, that term is often cited as one of the most significant barriers, but it is important to dig a bit deeper into what this means. Resistance can be on an individual level, such as a parent or caregiver who is against or reticent against the idea of vaccination for their child, which often is really coming from a place of concern about their child's safety and well-being. And I like to start discussions in the case of individual resistance by acknowledging that people who are very much for vaccination and people who are very much against vaccination are really coming from the same place. They're coming from a place of concern for their loved one. Someone who very much wants to get their child vaccinated wants to do so because they see the importance of that vaccine in protecting the overall health of their child. And someone who doesn't want to have their child vaccinated isn't looking for their child to acquire an infectious disease. They're also looking for a way to protect their child from something that they may perceive as harmful. Resistance can also be on a group or population level, such as certain communities that are actively encouraging their members to refuse vaccination, or in some extreme cases, coordinating active attacks or sabotage on vaccination sites or workers. And this can stem from a host of reasons as well. Significant institutional mistrust exists in many communities. This can be related to previous experiences, spillover from lack of satisfaction with other healthcare services or interventions, and often a combination of both. There can be overlap also between individual resistance and community resistance, but the approach to addressing them is often quite different. And furthermore, working with communities can do much more in many cases to alleviate individual level resistance than efforts aimed at contradicting or addressing individual concerns will have on community level resistance. That's not to say that individual concerns should be minimized and not addressed, but if we're looking at a public health perspective rather than an individual clinician perspective, the ability to appropriately engage communities that are reticent to have their members vaccinated or who are encouraging their members to not be vaccinated can go a long way in addressing some of the individual level resistance that may be encountered in a public health emergency. So again, getting to the example of the Ebola epidemic in Eastern Congo in 2018 to 2020. This was the first time that a vaccine was actually available in the toolkit to fight the Ebola epidemic. The largest Ebola epidemic in history occurred from late 2013 until 2016 in West Africa, at which time there were close to 30,000 confirmed cases, over 11,000 deaths. And work on a vaccine against the Zaire strain of Ebola responsible for that outbreak had been ongoing for some time. And clinical trials were actually done at the end of the West Africa epidemic, which did show effectiveness of the first Ebola vaccine. So in 2018, when Ebola cases surged in the northeast of DRC, the hopes were very high that this vaccine would limit the size and lethality of the epidemic. Nevertheless, despite the fact that over 300,000 doses of the vaccine, which is known as RVSV, or currently now the proprietary name Ervebo, being administered, this still ended up as the second largest epidemic ever recorded, with nearly 3,500 cases, and amongst them 171 healthcare workers, and over 2,200 people died, which results in a case fatality rate of about 66%, which is not particularly different than previous outbreaks. So the deployment of the vaccine did very little to reduce the mortality rate of this epidemic. And that's also given the fact that this epidemic also had for the first time monoclonal antibody therapies deployed as treatments for those who were testing positive. So why did this happen? In this context, particularly early in the outbreak, the demand for vaccination among the population was actually very high. So that goes along with the fundamental public health assumption mentioned earlier, that if a vaccine is available, that people will accept it and that people will want it. Additionally, in this area of DRC, there's actually a generally high confidence in the effective vaccines in this region, and vaccination efforts are generally very well supported. However, the number of doses of this vaccine was very limited, and in order to respond to this limited supply, the eligibility criteria for the vaccine were very narrow and depended on the identification of contacts of a case, so someone who had direct contact with someone who was diagnosed with Ebola, as well as their contacts, known as contacts of contacts. Frontline health workers were also prioritized, but not all of them. There was prioritization of public over private, despite the fact that the majority of the population didn't access public services as a frontline response to family illness. And other frontline workers, such as moto taxi drivers, religious personnel who perform burial rites, and others likely at risk, were not initially eligible for the vaccine due to issues such as wanting to limit the numbers, requiring vaccination or requiring identification of someone's essential worker status, etc. There was a very little discussion with the community as to who should be considered a priority for vaccinating frontline staff, and a failure to capitalize on the initial enthusiasm for vaccination. The result was eligibility lists. Anytime a vaccination team was deployed, they were deployed with a list of people who were eligible for vaccination, and in order to receive the vaccine, people had to prove that they were on the list. These lists were fraught with allegations of corruption. For example, you could pay to be on the list. Family members of important community members and officials were often on the list despite rumors that they had had no contact with Ebola patients. And additionally, as vaccines were often given to contacts of cases, as opposed to the contacts of contacts, because the contacts were easier to find and identify than the contacts of contacts, a number of these individuals were already incubating the virus at the time of their vaccination, and therefore a number of them became ill themselves. Public health messaging that went on at that time implied that vaccination as post-exposure would prevent the development of the disease, which provoked a significant amount of confusion in the population, and as well as anger when contacts became sick despite being vaccinated, and eventually led to a rumor spreading that the vaccine actually caused the illness, which was detrimental to ongoing vaccine efforts. In order to address community resistance, one of the pillars of the Ebola response determined by the WHO and partners was community engagement. Yet in many cases, the concerns listed above were not dealt with in a timely or appropriate manner. Additionally, in a socio-political context of alienation and neglect, long-term violence, and numerous other issues affecting population health, such as malaria, malnutrition, and high levels of measles endemicity, there was very little trust in a response for a poorly understood illness, spearheaded by entities in which there was very little institutional confidence. One phrase that we heard very often was, why is the government helping us now when they've never cared about us before? And you only care about us now because we're contagious and you don't want the Westerners to get it. Messaging around community engagement in many cases did not take into account the very real observations leading to the changing opinion toward vaccination in this context. And in many regions, high demand for vaccination shifted to outright refusal and resistance, and in many cases, violence towards vaccination teams. So not only was the vaccination strategy not well understood, the perceived consequences in certain cases may very well have contributed to more infections. So again, contributed to overall response and mistrust in the response as a whole. I mentioned issues of violence against healthcare workers, and resistance to vaccination led also to resistance against contact tracing efforts, resistance against other areas of the epidemic, such as safe burial practices, resistance to bring people to healthcare facilities to receive treatment. A number of the facilities where Ebola patients were being treated were targeted. 2 of our facilities were burned down. And this may, in fact, have contributed to prolongation of the epidemic. So how can we do better? Again, this is a big topic and a short period of time for me to cover it in. And so what's coming up in the next couple of slides actually is a lot of questions to sort of guide not only a response, but to hopefully broaden how we, as responders to complex emergencies such as epidemics, can hopefully get a little bit better at ensuring that our efforts are in line with what the community feels as important. There needs to be improved transparency from public health experts when communicating risk and uncertainty. Risk needs to be put into perspective, and the act of balancing multiple risks also needs to be explained. In a complex situation such as an epidemic or other big health crisis, there's very rarely a situation where the choice is between something that's completely correct or completely incorrect. It's much more frequently a choice between, essentially 2 evils, picking between 2 risk scenarios. This is risk scenario A, and this is risk scenario B. And experts, we often choose. And when we're choosing risk scenario A over risk scenario B, the communication that we give to people needs to give them credit to understand that kind of nuance and the insight that we're picking between 2 things that we really don't know all of the consequences of, and we're doing our best. And here is what we've decided. It may not even be a full decision. It may be a discussion that is undertaken with community leaders to say, here's risk scenario A and here's risk scenario B. Which do you think is the one that's going to be better for your community, knowing that we can't get this completely right? And risks need to be put into locally understandable terms. When discussing the implementation of health interventions with communities, an open acknowledgement of some of the reasons for mistrust is also necessary. And I think this is something that's very important, and we don't do it often enough. And we don't do it as, as someone who comes from a group of people that is associated with a lot of harm to various groups worldwide, government officials, health officials, settlers involved, in colonization activities. There are a lot of reasons for a lot of populations not to trust governments and not to trust those so-called experts who are coming into their communities. And I think that needs to be openly acknowledged when we're talking to communities and when we are planning interventions. We have done significant harm to your community in the past under the guise of doing good. And it is understandable that there's little trust in what we are doing now. How can we work together? How can we manage this as a team? Who should we be talking to? Who should be talking to people in this community? And I think what we also need to accept in many of these cases is less clear successes. We're not going to be able necessarily to implement all of the things that we think are the most important. This is the price for past wrongs. And those investments in something that is good enough and that is going to still do some good and reduce a lot of harm can be seen as an investment in future health efforts that will hopefully contribute to that building of trust. I put together just a short little reading list because I also know that there's nothing that university students love to do more than read more things. But I'm happy to share that with the organizers if anyone's interested in just a short reading list about that. And with that, I think I'm pretty much done. So I will stop sharing my screen and I'm happy to take a few questions.